Good afternoon, everyone. This is Polly Kurtz. Welcome to the Collaborative Family Healthcare Association's monthly webinar series. This month, we are very pleased to bring you a webinar from our Families and Health Special Interest Group. The name of today's webinar is Taming Wild Families in the Exam Room, and we're very anxious to get going. Before we do, for those of you who aren't familiar with CFHA and the Collaborative Family Healthcare Association, let me tell you just a bit about it. We are a member-based, member-driven, multidisciplinary collaborative organization. Our mission is to promote a comprehensive and cost-effective models of healthcare delivery that integrate mind and body, individual and family, patients, providers, and community. We have across the United States, Canada, and a few members internationally, probably close to 650 members. We hold an annual conference each year in the fall and offer a variety of educational opportunities each month. This happens to be one of those opportunities. Before we get started, I'd like to tell you just a little bit about our three speakers today. Dr. Caitlin Leckie completed a Certificate of Advanced Specialization in Medical Family Therapy, co-sponsored by the University of Colorado School of Medicine and St. Mary's Family Medicine Residency. She earned her doctoral degree in Marriage and Family Therapy at Texas Tech University, where she also obtained a Master's of Science. Caitlin began her medical family therapy career in pediatrics, oncology, intensive care, and the inpatient setting, but she is equally passionate about working with families across their lifespan. She serves as the chair of CFHA's Families and Health Interest Group and is licensed as a Marriage and Family Therapist Associate in Texas. Stephen Mitchell is a doctoral student in St. Louis University's Medical Family Therapy program. He currently is a Medical Family Therapy Fellow at St. Mary's Family Medicine Residency in Grand Junction, Colorado. He is a licensed professional counselor in both Missouri and Colorado. His research interests are loss and grief, particularly in regards to infertility, miscarriage, pregnancy, and birth. Additionally, he is interested in the connection between attachment theory and leadership development in pastors and doctors. And finally, Dr. Sabrina Mitchell is the Associate Program Director at St. Mary's Family Medicine Residency in Grand Junction, Colorado. She is board certified in family practice and hospice and palliative care. She is passionate about her resident education and teaching the hidden curriculum of surviving as a family practice doctor. Her clinical interests are osteopathic manipulation, shared decision-making with patients, and palliative care. Before we get started with the webinar, I'd like to take a few minutes and go through some simple housekeeping. You will have an opportunity today to answer questions or ask questions and chat. You'll notice in the bottom of your toolbar there is a section for questions, and there is also a chat section that you can enter information and correspond with others. You will see you can enter a question for staff. If you're not able to access that chat button, please go ahead and enter a question so we can make sure we can problem solve around that. We'll open up the question. I believe the speakers today would like some open dialogue, so feel free to use those functions. If you would actually like to use the microphone or telephone capability on your computer, you are also welcome to raise your hand. There is a little green hand next to your name in the attendee bar. Just hit that green button and I will unmute you and you can raise your hand or you can ask your question verbally. So without further ado, we're going to go ahead and get started. I'm going to pass the mic to Dr. Leckie, who is going to tell you just a bit more about the Families and Health Special Interest Group. Caitlin?
Thank you, Polly. I am very excited today to be able to give some information about the Families and Health Interest Group and also to kick off our first involvement with the webinar. So first of all, the Families and Health Interest Group is part of the Collaborative Family Healthcare Association. Our mission is to promote a family-centered approach within CFHA and other healthcare organizations, and to foster collaboration in scholarship, education, training, practice, and policy. Basically, our vision is improved healthcare through engaged families and collaborative relationships. Some of the activities that we are involved in order to promote this vision are things like promoting a family focus within CFHA, especially at the annual conference, and we're looking to increase the number of family-focused submissions we have for our proposals for the conference presentations. We're also really interested in educating group members on family-related topics, which is part of this webinar series. And then we're working on building our resource page on the CFHA website so that we can help disseminate family-focused and family-centered activities and interventions and assessment tools so that we can share these resources with one another. So I would like to go ahead and pass this on to Stephen Mitchell, who can tell us more about how our topic today relates to family-focused care and why we feel this is so important in the healthcare setting. Stephen?
Yeah, thank you, Caitlin. Well, good afternoon, everybody. Really thank you for joining us today for the webinar. And I think we've all, as therapists, have had experiences with different challenging families. And sort of the impetus for what we're doing today is thinking through how do you address challenging families, challenging interpersonal dynamics that are presented, whether it's in a traditional therapy setting or in a primary care setting. Dr. Mitchell, myself, and Caitlin, we all work in primary care settings, but also feel that what we're talking about today really extends beyond that to just general therapeutic skills that hopefully you can use in your practice, but also if you are a behavioral science educator, can use in helping doctors understand maybe how to use some of these therapeutic techniques with their patients. So one of the things that I think is most important, first of all, is to think about the families that we see and some of the things that might be impacting their lives. Because I think it could be very easy to just think, well, we have a challenging family, maybe there's kids who are bouncing all over the room, or they won't listen to their parents, or parents who seem uninvolved or disengaged. And I think it's easy to look at those families and say, you know what, you're kind of your own worst enemy. And, if you could kind of develop some better parenting skills or figure out how to manage your kids better, then our doctor's visit would go better, or our therapy session would go better, or kind of your kids' behavior in a school setting would go better, or at home. And so I think it's very easy to kind of get there as far as thinking about patients and saying, this is maybe a difficulty that you're having because of a lack of skills on your part. And however, I think something that I have been reminded of is I have a family that I work with, and their family has quite a few children, and each of the children have different behavioral issues, whether it's ADHD or encopresis or things like that. And they historically schedule an appointment and they miss an appointment, schedule an appointment and then miss an appointment. And, I was having some of those thoughts of, you know what, they're just not following through, they're not engaged, they're apathetic about care. And then I ran into this family in the waiting room one day, and the father said to me, hey, we're really sorry that we missed our last appointment, but we only had enough gas to take our kids to school and get back home. And we just couldn't afford to put any more gas in our car and make it to the doctor's office. And I think the point that impresses upon me is the idea that there's all these different contexts that families exist in. They have financial worries, they have work worries, they have just general day-to-day stress, medical concerns, have a personal history that they bring to their life. Maybe it's family structure, maybe it's a blended family or a single-parent family, or grandparents taking care of children. And all of these factors influence a family's interpersonal presentation in the primary care setting or in your therapy rooms. And I think it's just vital to remember that some questions that we can ask are there other factors outside of what I'm seeing right now that are hindering the functioning of the family? What areas of their life, whether it's their personal history or their ability to pay for gas, are influencing their ability to engage care and how they're presenting to me now? And I think that that's a helpful place to start. And I think another helpful place to start in understanding that and creating curiosity about patients is thinking about ourselves as the providers, and recognizing that we also come to our patient interactions with all of these factors influencing us. You know, I'm reminded of, I have a 3-year-old son, and one particular evening I was putting him to sleep, and it had been a long day of work for me. I was also just experiencing some stress as far as trying to kind of complete some things related to my dissertation. You know, there's just the daily stress of being parents, and you know, all these things were kind of piling up, and I was ready to get my son to sleep and kind of relax. And as I was laying beside him in bed and trying to help him, he punches me in the face. And you know, I kind of garnered all my therapeutic skills and reflected to him that he was probably disappointed about having to sleep, and that he was feeling concerned about you know, not being able to play, and trying to do all those things that we learn in therapy, and it was really effective because he punched me in the face again. And in that moment, I became quite furious. And I remember picking my son up, and I kind of squeezed him a bit harder than I normally would, and I stormed out of the room. And I was going to sit him down on the couch, and we were going to have a talk face-to-face. And as I was doing that, you know, this might seem a little shocking, but I had this desire. I really wanted to just throw him down on the couch and just sort of make him, in a way, feel how angry I was. And as I was walking with him, my sweet boy says to me, "Gentle, Daddy, gentle, Dad." And I think in that moment, what I realized is that, you know what, I can also get to some of the places that the patients we see get to, and that I can struggle with my interpersonal interactions with my own family, and that sometimes my kids don't behave like I would want them, and sometimes I don't react like I would want to, and sometimes I don't have the skills in that present moment to know what to do when my son punches me in the face. And so I think that that's a helpful thing for me to remember, because I think it gives me access to being able to understand where some of my other patients might come. And so as we come to this presentation, I think that's a good place to start, to try and locate some curiosity and compassion for these difficult families, recognizing that maybe we're not too far off from where they have found themselves, and that maybe we are also prone to some of the same struggles that they have.
So I'm going to start by talking a little bit more about just logistics and setting up your space for success. And so a lot of times we've got kids of various ages coming into our office, and maybe they're the patient, maybe they're not. And so it's always good to start by having some safe stimulation available in the exam rooms and the waiting room, so that they have something appropriate to do and not having your expensive things sitting where kids can reach them if it's at all possible. So we always start with that. Depending on the age of the child, you want to think about not separating the child and the parent. And so I will often examine small children on their parent's lap if it's feasible to do that. Have the parent stand by the exam table if that's not feasible. And even when I have a parent who is the patient, I will sometimes have the child come sit next to them on the exam table or do something to engage them in the process rather than leaving them free to sort of roam about the exam room. And the other thing that I think is important is bringing the child when they're the patient into the visit by talking to them. Of course, you're going to get most of your history, depending on the age of the child, from the parent, but really looking at the child, talking to the child, calling them by name, getting their input on why they're at the doctor's office, and then confirming all of that with mom or dad, whoever's brought them in. So that's one place to start up in terms of setting your physical space up. The next thing about setting things up is sort of doing some expectation setting and education in the office, and you do that both with parents and with children. In terms of parents, I think sometimes they'll come to the office and kind of expect you to be in charge because they're in your office and expect you to manage perhaps what's okay in terms of their children's behavior. So I think it's good to just encourage parents to maintain control and to be the authoritarian figure initially, and then obviously if that's not working, then you can sort of model some behavior for parents as well. And so some kind of catchphrases that you might try using if you've got a situation where you'd like a parent to sort of step up and be more involved is just saying, I encourage parents to be very involved during the appointment, or it helps me to see your parenting style, so please maintain your parenting authority during the visit as if you were at home. And that gives the parent permission to continue in that role of parent and authoritarian figure, and it gives you an opportunity to see that interaction. So it's good for parents to understand that when they bring their kids into your office or their kids are with them on a visit, that they're still the primary ones that we're looking for to maintain control of the situation. And then when it comes to expectation setting for kids, I think you want to give children choices whenever possible, but you also need to make your expectations clear. And so one of the things that I talk frequently about with our interns when they come in and they're learning to do pediatric exams is to avoid using things like, is it okay if I look in your ears? Because they're at the doctor's office, and if they're there for an ear infection, you have to look in their ears. And so we want to give them choices, but not necessarily allow them to direct the visit. And so I'll often use phrases like, would you like me to look in your mouth first or your ears? And then they get to vote, and they have some control over what's happening, but you still have an opportunity to get the examination done that you need. Additionally, in terms of behavior in the office, if the parent is having some struggles kind of maintaining their authority, I will often step in initially with some kinder, gentler things like, here are some toys or books to play with. If you'd like to have anything else in the room, you need to ask me first. I have been known to get pretty directive in cases where I'm trying to examine one child, for example, and there's 2 or 3 others in the room, and I'll sort of have everybody pick a chair and sit down and no touching, and get fairly directive in those settings. And again, I think that can be modeling good behavior for the parent in terms of what the expectation is, at least when they come into my office and see me as a doctor, that I expect a certain amount of obedience in order just so that we can get the work done. And so if the parent's not able to do that on their own, it's an opportunity to do some education using the children and the parents as to what acceptable behavior is in that office setting at that time. And then finally, I think it's important, again, with regards to expectation setting, to make sure that if there is a mess left behind, that preferably the child, but if not the child, then the parent cleans up the mess. So if they've brought things in with them or food or what have you, and stuff is spilled on the floor, it's appropriate to ask the child to pick it up, and if the child isn't willing to comply, to then indicate to the parent that they need to clean up the room or put the toys and books back or those types of things before they leave the office. And I think that that's just, again, managing the expectation and sort of training and teaching folks when they come in to interact with you what the rules are in that environment. And there's certainly different rules that go with different environments and different behaviors that are okay in one place and not another. I think if you maintain your consistent expectation, then everybody involved kind of knows what to expect when they come to see you. Now I'm going to turn it back over to Caitlin.
Thank you, Sabrina. So as Sabrina was mentioning, it's really important to start with those things like parent education and expectations for the patient, whether that be the parent or the child. But it's also important to have things like choice and consistency and to keep those in mind. So as we're having this, I'm reading and seeing that we don't have access to the chat functionality, and then we do have access to the question functionality. Okay, so that will change a little bit. I was going to have some audience involvement on this slide, and we'll see if we're able to do that. So the main point here is to maintain consistency with your expectations. And one way to do that is to ignore minor annoyances. So I'd love to have some audience input, and you might have to do this through the question function rather than the chat function if you don't have access to that. But I'm curious about what minor ignorances you have had to ignore in your own practice. For example, I'll have a child who might come in and be humming or just making some sort of noise that's a little bit annoying but not necessarily disturbing me or other patients. So that might be a minor annoyance that I would ignore. So if you can, if you will type in the question function or the chat function, whichever you have access to, what other kind of minor annoyances are common for you to have to ignore, and how do you ignore those annoyances? Some of them are easier than others, definitely. And I'm also curious about what kind of battles you choose. So choosing your battles, I imagine anyone who's worked with children knows this is something that is important, to have to choose your battles and not nitpick on everything that is going on in the room, because we know exam rooms and therapy rooms can get fairly chaotic when children are involved. So if you can, and if you have any thoughts on what minor annoyances might you ignore, how do you ignore those, and what are some battles that you choose over others? And while I'm seeing if we can actually have some audience participation here, I'll provide a few more examples. So when it comes to choosing my battles, it's definitely if safety is an issue, then I want to step into that. But if it's not a safety issue and it's not disturbing my work with the child, for example, or it's not disturbing, the child's behavior is not disturbing another patient, for example, then I might let that slide. So it looks like perhaps we don't have the option to get audience participation, so I'm going to skip that part. But I would encourage you to think about, just to yourself, what are your basic expectations for an encounter? And by that I mean, what are your basic expectations for a parent, for the caregiver, for the patient, and also for the sibling? If you expect that they're not going to be running around the exam room and you would like them to sit in a chair, then it's important for you to voice that up front, for example. So I think we'll go ahead and move on to the next slide then. One of the important parts as far as being able to ignore minor annoyances and choose your battles and be consistent with your own expectations, I believe, is to be able to be present and be, let's see, I think perhaps we have two comments or questions. I can't see them, so I'm going to have Polly or Stephen chime in and choose, okay, so I see. So choose to redirect, fighting and bullying. So those would be examples of, on that previous slide, things that you're going to choose your battles about. And one way to ignore those annoyances is redirecting. And I think that is an awesome piece of advice that I believe we got from Randall Wright. His experience would be to redirect. So fighting, bullying, those are things that he's going to not let slide. He wants to be able to call that out and redirect it. And I agree, those are definitely behaviors that you would not want to allow to continue. So I'm also seeing another comment, I may not ignore, but may point out and explain that I need them to pay attention to mom or their brother or their sister or dad. So can you please be quiet for a moment? So that's a great way to redirect, is asking them to be quiet, for example. And then we have another comment that someone's had success with asking the child, clap your hands as loud as you can. That's definitely a wonderful redirection. It's not going to hurt anyone, but that's definitely a great way to distract siblings. And I think that's a great piece of experience that we have an audience member sharing with us, is having some way to distract the siblings in a way that's not going to interfere with your exam or interfere with your ability to engage the family or the primary patient. Mm-hmm. Wonderful. So I think we might have a few more questions and things coming in, and I think it looks like Polly is having to type those in to us. So as we get those, I will check in with them. I'm going to move on, though, to the next slide that you see here. So as I was saying, one of the difficult things, as we all know, when you're in a busy primary care, specialty care, therapy practice, is being able to center yourself and be present and be in a good place even when you just walk into the room, so that you are able to ignore minor annoyances and choose your battles. And that's why I have this picture here, which is a picture of Lake Tekapo in New Zealand. And it's one of my, I suppose you'd call it a happy place, that if I need to center myself, or I need to take a nice deep breath of mountain air and I'm nowhere near the mountains, then I might think of this place, and you might have your own. I put it here as a reminder to you, but also because I'd like us to do just a quick activity together that I think is important to be able to ignore those minor annoyances and choose your battles. So one thing I like to tell people, and if you're familiar with mindfulness techniques, and you might be familiar with this one, is to have just a brief ritual activity that you can help yourself to be present and be able to take a deep breath before you maybe you feel like your head is going to explode when you're having some child who is annoying you, or a loud situation, or just a chaotic exam room. Before you even open the door to go into that exam room, if you just can take a deep breath to yourself. And what I'd like us to do right now is practice that by taking a nice big deep breath in through your nose, counting to 5, and then blowing it out through your mouth, counting to 5 again. Let's do a few of those together. So if you'll just go in through your nose, counting to 5. And then out through your mouth, a nice big exhale, counting to 5 again. Even just one of those inhales and exhales before you go in to meet with a patient or meet with a family, that can be a really great reminder to yourself to be present and to be centered, and also put you in a much better position to be able to ignore something annoying that a child is doing, or to be able to not snap at a parent, for example, and also to be able to do something that we would recommend for the next step, which would be recognizing strengths. So I'm going to take one more look here at the comments I see, just revisiting some of the questions I'd asked you to come up with some ideas on how you yourself ignore minor annoyances. So we had one more comment that was not expecting the child to sit through the exam. In other words, if the child is not disrupting things by walking around the room, then going ahead and letting them. So absolutely, that's a great example of picking a battle, is that maybe the child's not sitting in a chair like you would like them to ideally, but if they're not hurting anything and they're not disrupting anything or damaging any equipment, then absolutely letting them be able to walk around the room is totally fine. That's a great example. So in addition to having that choice and consistency, it's also important to acknowledge the parent's strengths and successes. And we had one more comment that someone had suggested, was acknowledging the feeling the child may be feeling. So what might the child be feeling? For example, if the child's about to get a shot, then even just acknowledging, recognizing that fear and that they might be afraid and providing comfort. That's a great piece of advice. So when it comes to highlighting strengths and successes, I think this is very important because so many of the patients that we interact with, this is not their norm. They are often focused more on those realms that Stephen was talking about, the context where there are stressors. Most of their attention is centered on what needs to happen next or what's not going well rather than what is going well. And often I think we perpetuate this when they come to the doctor, when they come to the therapist, because often we are focused on, well, what needs to happen now instead of celebrating the strengths and the successes. So especially when it comes to parents who are struggling with even just their child's behavior, this is a place that we really, as clinicians, can shine. So a couple examples on how to highlight strengths and successes. This is really focused on the parent, although it certainly could be focused on the child as well. So a couple examples here would be, your child really responded well when you, for example, redirected him away from the stethoscope, or when you used a firm voice to ask them not to play with that. So that would be a good example of how to highlight strengths and successes of a patient. Another one could just be, thank you for setting limits with your child. Just highlighting those basic things that a lot of parents don't realize that they are doing something well. Another example, would you please do so-and-so again? You did that very well. For example, if you have a parent offering choices that they're happy with, that would be something. Would you please offer your child a choice again? You did that very well. It worked very well. These are definitely all examples, and I imagine that you yourself could think of some more ways to highlight what a parent or caregiver is doing well in an encounter. So you might think of, for yourself, it might even, and for a lot of the patients that we interact with, it might just be coming to the visit. I know that in Grand Junction, we often had difficulty with families even just bringing their child in. And that might be the only thing. You might be pretty frustrated with the patient. That might be the only thing that you can acknowledge in that moment, is just, we're so happy that you're here today. And that's okay. That's still wonderful. It's still highlighting their strengths and successes. So when it comes to having to step in and maybe get a little more directive with parents and caregivers, we would encourage you to use an economy of words to empower the parents. And what we mean by that is, don't give them a long lecture. Just highlight right away, for example, is it okay for you that your child just hit you in the face or threw a toy at his sister? So being able to highlight succinctly and directly and be hands-on and proactive rather than preaching or lecturing or jumping in and parenting for them. For example, if you have a child throw a toy or hit his mother, you might say, what typically works for you to redirect your child when she does throw a toy at you or when she does hit you in the face? And that way you're still directing the parent, to be in control, but you're also, in a way, modeling for them that this is appropriate for them, and they might need a little bit of a push in the right direction, because that can be pretty difficult for a parent to feel like they're on the spot and that there's an expert watching them and maybe feeling like they're judging their every moment. So having little prompts like this can be helpful for the parent to be able to jump in and take control. So another thing that you might say, will you please try that now? So identifying, is it okay for you that your child just did that? What do you typically do in this situation? How do you typically redirect your child? Would you please try that now? You're still leaving it up to the parent to turn the situation around and to remain in control of their child. And it might come to where you need to ask, please, I need you to prevent your child from doing that, from twirling the stethoscope around his head, from throwing things at his sister. That might take a little more direction from you, is that you need to step in and say something like that. And it might need even perhaps come to, please sit between your children, especially if I know we had a mention earlier of bullying or fighting between siblings. So that's definitely not uncommon to have to separate the children, and sometimes that might take some direction from you as far as please sit between your children. So these are some good examples of just using short, succinct ways to keep the parent or caregiver in control without parenting for them. And with that, I think we are going to talk a bit more about situations that are a little more difficult, and I'm going to hand it back to Stephen.
Yeah, and so I think all of us who have worked with families recognize that violence is a real part of what happens in families. And just because someone is at the doctor's office or at a therapy session doesn't mean that that violence won't occur. And so I'm just trying to think through what are some ways in the moment when you're working with families that you can address something like violence. And I think one of the first ways is if it does feel like a safe environment, perhaps it's like Caitlin was describing, a situation where some siblings are bullying one another, you know, and the parent won't step in to protect the children. Where if you feel comfortable, you can step in and try separate the children in a way that feels appropriate, and that would protect both of them. I think maybe one of the most helpful things to do is I think that this kind of is a tough situation when you're alone in the room, and so one of the things that might be helpful is just to invite someone else into the room to help you problem solve, to help you feel a little bit more calm. Maybe it's a way for you to take that deep breath and be mindful, because we all know that when violence kind of enters the situation and enters into interpersonal interactions, our anxiety level can go up, which can also hinder some of our ability to just think rationally and logically. And so by perhaps stepping out, grabbing a colleague, or in the doctor's situation, a nurse or a fellow doctor to come in and say, hey, help me with this situation, would be a good way to address the violence that's taking place. And I think one of the primary reasons this is important is because you want your setting that your patients come to be a safe place. So not only are you trying to provide safety for the patients that you see, but also for your fellow staff workers and colleagues. And so part of this is helping families, but it's also maintaining an environment, just like we talked about a little bit earlier, even as far as how you set up an exam room. This is more of how you set up a clinic or an office so that it's known as a safe place. And so these think that this is why this becomes particularly important. And then if it feels that calling in a nurse or a colleague is ineffective, then I think it's appropriate to just finish the appointment, to kind of note to the patients, to the family that, you know what, this interpersonal interaction is in a sense too much for our current situation. This isn't really what we want to be having happen. So we're going to end our appointment today and we'll welcome you to come back and for us to readdress these things and to even readdress this interaction where we can talk about it or interact in a way that feels safe for everyone. And I think in some ways that's a great way to model for patients and families just what appropriate boundaries might look like and how to ask for them. I think sometimes a lot of times our patients might struggle with knowing even how to ask for appropriate boundaries. And so I think that you can do that by addressing the situation in this way. I think always, of course, if there is violence that is between an adult and a minor, that's a different situation where there would have to be perhaps a referral to Child Protective Services, and of course that is something that you will have reviewed with the families and confidentiality that they'll be aware of, and so these situations are more in circumstances where those types of behaviors are not taking place. Of course, if they did, then I think it would be appropriate to also call CPS if needed. And so if you've finished the appointment and if this is an interaction, interpersonal behavior that continues repeatedly, there's always the consideration of perhaps dismissing the family, whether it's from continuing on in therapy or in a primary clinic setting. There are moments, hopefully not a lot, but there are moments when patients are dismissed from that clinic simply because there's not a adherence or compliance with clinic policy or, like I said, creating a safe environment. And so this is, of course, something that you would do kind of in consultation with other colleagues and also with the director of the clinic or the director of your practice. And I think one of the things that's difficult about this is, for example, at our clinic here, it's a safety net clinic, and so it's one of the last places for people to receive care. And so to dismiss a family from care would mean that then they would have a very difficult time finding that help otherwise. And so that's something that I really need to take into account. And so I think one of the things that we would be curious to hear about from y'all, and Kevin, you're going to have to man the questions here because we're, for some reason, I'm not able to view them right now. But wanted to know if y'all, what your experiences have been with families and violence, and if there are circumstances and situations that you feel would be appropriate to dismiss families, or other ways that you might have dealt with these challenging circumstances.
This might be up to Polly to, I think she's the one who has the access to the questions. So we'll see if we get any.
And if we can't get any of the questions, that's okay.
No, that's fine, Stephen. I'll either transcribe them or read them to you as they come. So the first one is, can you talk about how you might be able to use a behavioral health consultant to assist?
Yes, in a situation where there is violence, I think that's what the question is referring to. I think in this is actually a situation that I think BHCs are often called into. There's a patient who is having a difficult response or reaction to just to the visit, and if there is violence, I think that this would be the situation where maybe we're that colleague who's called into the room to help calm and to help provide a non-anxious presence that can kind of relieve a doctor and or a nurse or a colleague. And I think sometimes when you introduce a new person like a behavioral health consultant, it kind of shifts the energy of the room. So I think it would be then walking in and using all your skills and abilities of kind of crisis management, trying to assess for safety, trying to help those who seem like they're the most activated become calm, whether that's, even just asking them, hey, can you step out just for a minute, and then come back in. And so I think that that's how BHC might be called in to help in that scenario.
Stephen, there's another...
We also had a comment from...
Yes, I see that.
Go ahead, Polly.
And so there's a suggestion here that one option, if there's siblings that are being violent with each other, is to only allow parents to bring one child to an appointment at a time. And I think that that is definitely a really great suggestion, particularly if it's behavior that continues to happen. And I think in those individual times for that parent and child, and the goal would be to work towards being able to have another joint appointment. And so working with the parent and that child on individual things about, how come, it's difficult for you to not be violent towards your sibling, and then using some of those solution-focused skills of finding the exceptions of when the siblings are getting along, and then seeing if you can apply that to their doctor's visits. And that could be a great experience of success for them, and something where you could say, look at how far we've come. This used to be challenging for you, and now these are the strengths that you've shown, and y'all can meet again together. So that would be the hope, but I think that's a great suggestion of maybe having separate appointments in the time being. Yeah, and I see another comment here that it's this idea of dismissing is a really challenging idea, because I do think that, as professionals, we do want to help, and to dismiss a patient might seem like we failed. And that's a comment from Colin Fogarty, and I think that's a good point, that and something we have to assess, we have to judge. So is my continuing to work with this family, is it because I'm kind of trying to ward off that sense of failure, and is that clinically the best thing for them? It could be. Or would the best clinical decision be for them to try and pursue help elsewhere? It's not an easy thing to answer. I think that it goes on a case-by-case basis, and that's why your colleagues are so important, to sit down and talk with them and say, am I missing something? What would you do? What do you suggest?
I think that's a great point, and it seems like it provides a wonderful opportunity to sit down as a clinic or as a practice and determine what, if anything, could we have done differently with this family or with this situation to keep that from happening again.
Yeah, then there's just the follow-up comment saying that, as colleagues, we can if we feel that it is a good decision to dismiss a patient, to encourage one another and to kind of support that decision so that we don't have that sense of, well, I failed, or, could there have been something else done? But hearing other clinical wisdom can kind of bolster our psyche, is what the comment says. So I saw two questions here. There's one that said, overall, how can a DBD assist in this process? I'm not familiar with what the abbreviation DBD means.
Stephen, sorry, it should be DBH.
A DBH? Okay. And I'm not familiar with what that is. What is a DBH? Is that...
Let's see. Hopefully, a doctor of behavioral health.
Okay, thank you. Okay. Sorry for that. Well, I think the director of behavioral health, it depends on if sometimes in settings, I think helping nursing staff, helping doctors, if understand this dynamic and that it happens. I think sometimes, as kind of therapists, we're more accustomed to dealing with kind of chaotic families and some of the more serious things like violence that take place, and maybe some of our other colleagues and staff haven't seen that. And so I think part of it is just normalizing the fact that, yes, this does happen, and yes, it is difficult, and then also maybe walking them through maybe a 4-step process like this. So when you do interact with patients, these are kind of the steps, and then also getting a clinic protocol. So what does our clinic do when we have patients or families like this? And that would be a conversation between the director of behavioral health and the clinic director and the residency director, and so and then it's passing that on to the residents, to the doctors, and so I see that more of the role being supporting and teaching is how I think that the director of behavioral health could engage that process. And then there's the question of how do all these behaviors work in a fast-paced primary care setting. I can see this in a therapy session, but how do you manage this in a primary care setting? And I think that in my experience that it's not too different. I think when there's issues of violence, because they're so serious, some of that fast-paced, we're trying to get through appointments kind of stuff halts because you've got to address the seriousness of the issue, and sometimes that takes time. And so I think that maybe part of it is it won't be as fast-paced, and it won't be as quick, and maybe you will be behind in your kind of with your next appointments. I think the way to manage time would be to, if you know that you have a family who's maybe manifesting some of these behaviors, maybe it's a difficult first appointment, but that you plan for these appointments in the future. And so that when you have your morning huddle, or when you are in a precepting room and you see this family on the schedule, you talk with the doctor. That doctor knows to come and talk with you, and you, in a sense, plan for how are we going to do this in a way that feels like it pays attention to the time constraints, but also it pays attention to the patient's needs. And so there might be a scenario where that family always has co-visits, and it's always the doctor and the behavioral health consultant, or someone that family trusts, in the clinic. Maybe there's a nurse on staff that they really connect with and really have a strong relationship with. And so maybe it's always the doctor and that nurse meeting together. And so I think that initially this doesn't fit very well. Violence doesn't fit very well in a fast-paced primary care setting. What you're trying to do is be able to address those issues in the future, and those are some ways to do that.
And I would just add, from a primary care perspective, I mean, I think if you're talking about the behaviors overall, not necessarily just violence, but behaviors that make it difficult to get through your visit, I think that it probably actually is faster to incorporate some of these quick catches and really starting the visit and kind of, as we said, sort of making your expectations clear and moving forward. It's probably actually faster, I think, to do that than to let it go and go and go. I've often found that, you know, sometimes just sort of heading right into it and facing it head on, even though it seems daunting, is the faster way through than trying to hope that it doesn't happen. I think additionally, if you've set your expectations as you and the family get to know each other, the amount of time that you have to intervene tends to shrink. And then when you're speaking about kind of what I call the schedule busters, you know, when something is just really amiss, and whether that's violence or just some, you know, very involved or severe problem, we're very blessed in our clinic that we have behaviorists that we can come and they save our bacon every day, coming in and sort of stepping in and being able to dive into some of those issues that free me up to go move on to the next patient. And so we're lucky in that respect. And I know the idea of collaborative healthcare is gaining traction, and so it would certainly make a good case to have that available in other offices as well.
Sabrina, I just want to add one thing to what you said that I think will help frame this whole presentation and also help with Michelle's question there. Is if we advance the slide, we do have kind of a synopsis of steps to do this behavioral approach in your setting, and it was designed for the brief examination room interaction kind of settings. And so this slide just provides a synopsis of these are the steps that we've been talking about, and I think hopefully it will answer that question that Michelle had about how do we actually implement these things in a fast-paced primary care setting.
Very good.
Yeah, and I'm not sure how we're doing on time. Yeah.
Yeah, I think we just have a minute or two left. Do you guys want to say a few last words and on this topic? I appreciate all of the audience participation today. Sorry it was a little awkward with the transcribing, but our speakers handled it wonderfully, and I appreciate all of it.
Thank you, Polly. The last slide that we have on here is just a couple of resources that you can direct patients to, parents and caregivers. Love and Logic and Triple P are both parenting programs. They're both focused on positive parenting, and I know in the Grand Junction setting we've recommended, for example, the Love and Logic classes that we have in the community. Those have been great resources, and so I listed those on here, and you can find out more about that Triple P. I know Matt Martin just did a blog post in the Families and Health blog about it, and then Love and Logic, both of those you can Google, but those are some great resources as well for directing parents to, and also just for your own education. One thing that I did forget to mention was our Families and Health interest group. Our next meeting, and we'd love to have everyone join, is on April 10th at 11 a.m. Mountain Time, and we'll send out future information about that and emails about how to join that meeting. But I'd love to have all of you join us. So thank you so much for attending our webinar today. We really appreciate the participation.
Yeah, thank you to our speakers today, and just a couple brief announcements. An evaluation will be coming to you via email. If you'll take just a few minutes and fill that out, it helps guide our future webinar programming and we'll give the speakers a bit of feedback about the presentation today. Also, our call for presentations for the 2015 conference in Portland, Oregon, October 15th through 17th is now open at the CFHA website, www.cfha.net. We have a special track this year related to families and health. So we're very interested in having presentations, as Caitlin mentioned earlier. So please take a look at that and consider submitting a proposal. Again, thanks to our speakers today, and we wish you all well.